Welcome to the Healthful Woman Podcast. Today's Monday, July 19th, 2021. Hope you're all enjoying your summer. Sarp Aksel joins me today to talk about thrombocytopenia in pregnancy. As we stated in the podcast title, thrombocytopenia is just the fancy word for low platelets. Sarp and I discuss why we care about platelets in pregnancy, why someone may have low platelets, and what we do about it. Hey, if you're new to the podcast, hope you have been enjoying them. Be sure to check out some of the older ones. Well, none are that old as we only started last year, but check them out. Also, be sure to check out our second podcast, High Risk Birth Stories, which drops every Thursday. Finally, if you're able to review us on Apple, I would really appreciate it. And I would really appreciate it if you gave us a 5-star review, if that's what you think. Thanks for listening, everyone. Have a great day. We'll see you on Thursday for High Risk Birth Stories. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, Sarp, Dr. Aksel, welcome back to the podcast. How goes it?
It goes. Good to be back.
Fantastic. We're recording in the middle to end of May. And it's pretty much right after all of the masking restrictions have started to lift, both from the CDC and now New York and other places. How's that going so far?
It's such a shocker to see your nose and mouth. It's very exciting.
Well,
glad it hasn't changed over the last year or so.
Yeah, not much as far as I can tell. In healthcare settings, they're still mandated. So we're wearing them around the office, but out on the street, we're seeing people's faces again. In people's homes and some places of business. I went to Starbucks this morning and I saw for the first time masking is optional, which was brand new. Just
Amazing.
Came up this morning, obviously.
A lot less smiling faces. I thought people smiled more, honestly.
Yeah, it's interesting because with the stores, at least, you know, we're in Manhattan, and Manhattan was pretty big on masking, maybe more so than some other places. And I think what's happening is some stores are finding that there's a subset of customers who are really happy about the fact that they can take off their mask and come in. And there's a certain subset that are very unhappy about the fact that others can take off their mask and come in. And it's probably going to take some time for this to sort of settle out, the dust settles, so to speak, on this.
Well, what a shocker that things are polarizing in this country at this point.
I'm not sure if that specifically falls along
Masks.
Party lines. Because in New York City, I think everyone falls very similarly on one side of a line.
I think
politically.
we're so excited about any kind of drama. Masks, like the most, we never would have thought about it before.
Yeah,
2 years ago, who would have thought that masks would have in any way, shape, or form been polarizing?
Yeah, I definitely think that anyone who bought stock in masks 1.5 years ago definitely rode that wave and did well, but unpredictable. Wonderful. Well, we're going to segue into something totally separate from COVID, and that is thrombocytopenia, which is a long word, which means low platelet count. It's one of those great situations where we get to come up with a fancy word to make us sound smarter than we truly are.
And terrified patients in the meantime.
Right. Thrombocytopenia. Am I going to live? Oh my God, that sounds horrible. So let's start from the beginning. So thrombocytopenia means a low platelet count. We're talking about this specifically in pregnancy, although it is something in a non-pregnant state potentially, but we're going to talk about pregnancy. What exactly are platelets? Why do we care about them?
Everyone's blood has various different components in it. Some parts of the blood carry oxygen. Other parts have, clotting factors. And that's kind of where the platelets come in. They help us clot our blood, whether it's a knee scrape or hemorrhage after a delivery. So they're kind of pretty important in making sure that we don't bleed out no matter what the cause.
Right. When people think of their, blood, a lot of them think on the sort of the realm of anemia, like what is my blood count? And that's really just the red blood cells. So the red blood cells are the most famous of what's in our blood, and that's what makes it red. And it's also what carries the oxygen. And sort of people think about that a lot. And there's obviously water, which gives it volume, but there's all these other things floating around that you really only know about if you don't have them. Like platelets, which help people clot if, either prevent them from bleeding or if they are bleeding, helps them stop. things that help fight infection, our white blood cells, a lot of stuff in there. So the platelet count is something that we focus on in pregnancy because women are going to come up to deliver where they're going to be in a situation where they're bleeding. And obviously, we would be concerned if they're low enough that they would bleed before then, but we just know that something's happening, right? If someone's coming up to surgery, for example, the surgeon's going to know what the platelet count is to make sure it's not low. And so the same way with pregnancy, everyone's coming up to a delivery one way or another, and we need to know what the platelet count is to make sure that she's going to be able to get through that safely and not bleed too much.
Absolutely.
And so how often do we find platelets that are low, and what do we even consider low numbers wise?
Right. So when we usually talk about them, we talk about them in the thousands. So, you might hear your doctor say you have a platelet count of 175 or 150. That doesn't necessarily mean that you only have 175 platelets in your body. It means you have thousands per certain amount of volume. And so when we talk about platelets, normally it can be anywhere from 150 to 450.
Right.
Can be normal outside of pregnancy. We've sort of set an arbitrary definition of less than 150 as being abnormal in pregnancy.
Yeah, and again, it's sort of some of the confusion that people have is the fact that we use a shorthand.
Right.
Like when we say 150, that's short for 150,000. Like if you look at the report, it'll say 150,000. We just call it 150 to be shorter. Everyone knows what we're talking about. If someone actually had 150, it'd be a big deal. And so I think most women end up having around 300,000, give or take. And when it starts dropping below 150, that's when we start talking about it. And it ends up being about 1 in 20 women will have this. Maybe 5% of pregnancies will have a platelet count under 150,000. And most of them are fine. Nothing's going to happen to them. Nothing's happened to their baby. Everything's going to go fine with their delivery. They're just sort of on watch,
right,
so to speak. So about 5% of people we put on watch with low platelets. And we try at the same time to notify them and not scare the hell out of them. And that's a fine line. You want people to know what's going on, but not scare them. And so we try to tell them, okay, like we're on notice, we're watching this, but we think most likely everything's going to be okay. And some people find that very terrifying, but hopefully not. Because again, it doesn't tend to be a very difficult problem for women from a health perspective.
You're totally right on that fine line that we toe between being informative and transparent about lab work, but also sort of not scaring people. Last week I had a patient with a platelet count of 148, and she was terrified. She was like, "What's going to happen? Am I going to bleed to death? Am I bleeding right now? Do I not know that I'm bleeding right now?" And so I think delivering that news oftentimes takes a little bit of finesse.
Right. And one of the interesting things about the way healthcare is nowadays is sometimes that decision's even out of our hands how to do it, because with portals and the lab giving patients access to their own results, which is a good thing. People should have access to their own healthcare information. They're going to get a result that says 148,000. It's in red. It says, warning, warning, danger, danger all over it.
Exclamation marks.
Yeah, there's exclamation points and it's flagged. Talk to your doctor. And people are like, oh my God, this is horrible. And we're like, no, it's okay. And sometimes even normal results get flagged because values that pregnant women have that are normal might be considered abnormal for the references the lab uses. They're not currently fine-tuned enough to say, okay, you're a 34-year-old pregnant woman, this value is normal for you. They just have a reference range, which is from some book that's usually from some 40-year-old man, right? That's sort of the typical, and that happens a lot as well. But for platelets in particular, it'll frequently scare people more than necessary just by looking at the lab reports. So, warning to everyone out there, when you look at your lab reports before having that onset of terror, make sure to speak to your doctor to see if it's okay, because usually it is. Because if it was a problem, they usually would have called you about it already. Now, in terms of the 5% of women who do have platelets that we consider low, there's a lot of reasons why they can be low. And it's important for us to try to figure out the reason, because there's different implications based on the reasons. Meaning, one of the reasons, for example, is that the platelets aren't even low. It's just when the machine that looks at the blood and spits out the result reads it wrong. And so why would that happen? In pregnancy, sometimes the platelets get sticky and they clump together. And so when the machine looks at them, normally the way it differentiates between a red blood cell, a white blood cell, and a platelet is the size, right? A white blood cell is very big, a red blood cell is like medium to small, and a platelet is tiny, like a dot on the screen. But if, let's say, 5,000 platelets sort of congregate together, it'll look like a big blob, and it'll count those 1,000 platelets instead as one white blood cell. And so sometimes you get back a result where the platelets are low, and all that has to happen is someone, not us, we're not really properly trained to do this, but like a hematologist or someone in a lab, looks under a microscope and says, no, they're clumped. The number is normal. The count is normal. They're going to work fine. You don't even have low platelets. It's just a consequence of having it done by a machine rather than being done by a human. And in those situations, like literally there's no problem. Like they're perfectly fine.
Yeah. And that definitely happens.
Yeah. And the only thing that needs to be done is sort of logistically, we have to verify that with someone close to delivery, that in fact, even though the machine says their count is low, that in fact it's normal. So that's one cause of low platelets, again, which they don't even have low platelets. The next most common cause is something that we call gestational thrombocytopenia, which is like a fancy term upon a fancy term, which basically means nothing. It means you're pregnant and your platelets are low. And it means we don't really know why. It's what we call a diagnosis of exclusion. There's a thought that something about pregnancy makes someone's platelets go down. We don't really know why. They're not ill. There doesn't seem to be any risk. They don't bleed more. It's just for whatever reason, their count is lower. And what counts of platelets do women typically have if that's the diagnosis we land on?
Usually, we're looking at counts between 100 and 150,000. And sometimes it'll dip a little bit below 100, but there are other conditions that you might want to make sure a patient doesn't have. But predominantly, they're hovering between 100 and 150.
Right. I mean, one of the ways we exclude it is that they're not crazy low. Like someone has a platelet count that's under 50. We're not going to call it gestational thrombocytopenia. We're going to think there's something more sinister going on. But when they sort of never get below 100 or below 90 or 80, and they're sort of in that range, it's frequently what it is because we don't find any other cause. And again, those women, even though the platelets drop during pregnancy, it does not tend to have any actual consequences health-wise for her or the baby or the delivery or anything like that. And so that's good. The other causes are the more rare ones. There's something called, here's a nice one, idiopathic thrombocytopenic purpura, which we call, because that's a mouthful, we call ITP for short. You may have heard the term ITP, but that's what it stands for. It is quite a situation to say to someone you have idiopathic thrombocytopenic purpura. I mean, literally, they're like getting their affairs in order. The concept of that is that there's an autoimmune condition in the mother, meaning she develops a condition where her body incorrectly recognizes her own platelets as foreign and says, I'm going to attack these and I'm going to kill them. And that happens sometimes conditions like lupus. It could happen rheumatoid arthritis or thyroid conditions where the body incorrectly identifies something that's supposed to be there as something that's not supposed to be there and starts attacking it. And based on what they're attacking, those where the symptoms are. So there is one for platelets. It's hard to know for sure because there isn't a good antibody test for this. It's not like you can draw blood tests and say, oh, you have this versus you don't. It's not a diagnosis of exclusion per se, but it's sort of one of these situations where if the platelets are dropping low enough that it's hard to call it gestational thrombocytopenia anymore, we sort of flip and say it's probably this ITP. And some people believe they're actually the same condition, just at different degrees. Some people believe gestational thrombocytopenia is like a temporary, mild form of ITP where women develop a few antibodies when they're pregnant. Some people believe they're totally separate. We don't really know, but the real practical distinction is the number. If the number is high enough, it's probably gestational. And in particular, if her numbers are high when she's not pregnant, it's probably gestational. Whereas if they're very low or if they're sort of borderline low when she's not pregnant, then it's probably some form of this ITP, which is autoimmune. The other ones are like medical problems. Like she has preeclampsia, which is a acute condition that happens in pregnancies, drop your platelets, or she develops some crazy medical condition, which could happen. But ultimately, I would say, in our experience, the two most common and the ones that we're almost always going back and forth on, trying to figure out what it is either gestational thrombocytopenia or ITP. Is that what you found in your own practice thus far?
It is. And a lot of the questions that I typically spend time in the office answering when platelet counts come up is really, there was nothing wrong with me before. Where is this coming from? Is it going to get better? And usually it's very reassuring. It's a simple explanation that this is probably pregnancy related and that it'll resolve. It'll go back to normal. If you never had abnormal values before outside of pregnancy, chances are that once you're done with the pregnancy, your levels are going to normalize again.
Yeah. And in terms of trying to differentiate whether it's gestational thrombocytopenia or whether it's ITP, it usually does not matter. There's not much of a significance between the two. There are some things we need to know we'll talk about, but basically the most important issue is what is the actual number? What is the platelet number? Meaning, if someone's platelet count is 90, it doesn't really make a difference to us what the diagnosis is. It's just that they're 90. Whereas same thing, if they're 60, it doesn't matter that much between those two, what the diagnosis is other than the number. And the reasons we care about the number is, number one, is the number high enough that she won't have an issue with bleeding, right? Like her own medical health, which is on our minds, but rarely an issue because they rarely drop low enough for that to be a concern. They'd have to drop below 50 for a C-section and below 20 for a vaginal delivery. So they can get really low before it affects the mother and her risk of bleeding. But what ends up happening practically, and this is what, 9 out of 10 or 99 out of 100 women who are talking about low platelets, the conversation is, can I get an epidural?
Right.
By I mean the woman in labor, not me, the doctor. That would be interesting if I had one in labor. So it's really an issue. Can she get an epidural? Why is it an issue getting an epidural if your platelets are low, potentially?
So when you're getting an epidural, it's a very small space that a trained anesthesiologist is placing a very small needle, but there can be some bleeding. And as we discussed, platelets are very instrumental in making sure that you don't continue bleeding, that you're able to clot if something goes wrong. So making sure that even if there is a little bit of bleeding in this very small space, making sure that it stops is important. Making sure it doesn't accumulate and you end up with something called a hematoma can be very important because in that small space, you have your spinal cord. And I've been told by neurologists, spinal cords are important and they should be left alone.
They should be left alone. It's a tough area because, number one, it's a very small space that they're working in and trying to get into. And number two, it can't be seen by them. They're doing it by feel, by touch, meaning if you're working on someone's arm and you're putting in stitches, you can see if they're bleeding or not. You just look at it and are they bleeding, not bleeding. Whereas if you're trying to work inside the body without opening the body, you have to just go by touch and by feel. And so the anesthesiologist would not know if there's bleeding internally that's not stopping near the level of the spine unless the patient had symptoms from that. And the symptoms, once that happens, is really dangerous, like severe pain, or she can't move her legs as well. I mean, when you start affecting the nerve and compressing the nerves, then sometimes you need emergency surgery, like spine surgery, to relieve that. So the anesthesiologists are justifiably and correctly very cautious about putting an epidural or a spinal if they're having a C-section, any needle inside someone's spine near their spinal cord or into their spinal cord when there's any concern that they may not have proper clotting and they may be at increased risk for bleeding. So there is no specific number cutoff for platelets above which it's safe and below which it's not safe. It's all the lower it gets, the higher the risk. And different anesthesiologists feel differently about this, and different women feel differently about this. And it ends up being a conversation about whether it's an option to get an epidural in labor or a spinal for a C-section based on the platelet count. And so that number is important.
And thankfully, you said a lot of really scary stuff, but thankfully it's very rare that we end up having patients who have a relatively normal platelet count end up being at high risk for those very severe and very serious complications from epidural placement.
Yeah, I mean, the risks of those are, in the 1 in 10,000s, 1 in 100,000, like that type of number that's very close to zero, but never zero. And part of the reason is that the anesthesiologists don't select sick people or people at increased risk to place the epidural. They place it in every single person 100%, then yeah, they'd have more complications, but they're able to say, no, you're at increased risk of bleeding, we're not going to do it. And so what happens is practically again, it depends where you are regionally in your own hospital. In our hospital, if the number's above 100,000, pretty much every anesthesiologist is comfortable putting in an epidural spinal. Again, if we think it's either gestational or ITP, if there's like a medical condition, that's a separate issue related to that condition. Above 90,000, that's probably the same. Even above 80,000, that's probably the same. And I would say above 70, the majority are probably okay with it. Maybe some aren't. Under 70 is where it starts getting difficult to find anesthesiologists who are comfortable with it. And there are some that might under unique circumstances based on specifically our history and what's going on. But that's when it really starts getting difficult to sort of know that an epidural spinal is an option for you once it gets below 80 or below 70. Now, let's say you have a patient who she doesn't want an epidural. She's like, great. Like, I'm not looking for an epidural. I was planning on, delivering naturally. I don't want one. I don't need one. Why would I care if my platelets are 60,000? How would you respond to that?
I know that at the end of this journey, you're going to deliver. And when you deliver, you're going to bleed. And so making sure that that bleed is as controlled as possible and that your body's natural instincts and systems in place to stop the bleeding are going to kick in is really important for me managing your labor and managing your delivery at the time that the baby comes out, whether that's vaginal or by cesarean. If your platelets are that low, I might consider giving you extra platelets. If they're under 50 or under 40,000, I might want to have additional blood available that's of your blood type. So there's a lot of preparation that might need to go into managing labor and delivery in someone whose platelets are very low, even if epidural isn't something that they're considering.
Yeah, and I agree. And what I also tell women is we don't know what's going to happen moving forward. We can't obviously predict. We can predict, but we can't tell what's going to happen in the future. And so if I have someone who says, I'm not going to get an epidural, I'll say, great. If you don't get an epidural, then it doesn't really matter if your platelets are 60. Assuming they stay there, they should be high enough that you won't bleed and you should have a safe delivery with those platelets. Okay. But what happens if in labor you change your mind and you're in a lot of pain and now you want an epidural? Not an option for you. There are other options for pain management and they exist and they have whatever efficacy to some degree, not as good as an epidural typically, but that option will be off the table. And if she says, well, I'm 100% sure I don't want an epidural, I'll say, fine. What if you ultimately need a cesarean, right? If that happens, and there's reasons why it happens. Typically for a cesarean, for a woman who does not have an epidural, they'll place a spinal, which is the same concept, which is the safest way to have anesthesia for cesarean. It's the way where you can remain awake during the cesarean and has the lowest risk of things like aspiration, where you get, contents into your lungs. And that's done with a needle in your back the same way. And so that won't be on the table for you as an option. And now if you need a cesarean, you have to be put to sleep, which is doable and usually safe, but higher risk. It's definitely not a good experience to be intubated and you're not awake when the baby's born. When you wake up, you have more pain because when they do the spinal, they inject morphine into your spine. And so there's a lot of things that on our end as the obstetricians, we think about, like what if A, what if B, what if C, what if D, that even if someone's, planned birth of E, if what they want and what they hope to have doesn't have an epidural in it, we know that there's always these other options that may come up. And so we think about those as well. And it's one reason why we might want someone's platelets to be in that zone where they could get an epidural, even if they don't plan on one, even if they strongly don't plan on one.
Absolutely.
And then in terms of what could we do if the platelets are, let's say, dropping below 70, what are the options in terms of treatment?
So if this is something that we're following routinely in the outpatient setting, in addition to getting regular levels, we might refer a patient to hematology. So we might consult the specialists in blood disorders. They might consider giving additional medications to help kind of build up and raise your platelet counts in hopes that when delivery comes, you have a robust number so that no matter what happens, we're prepared and we're safe.
Right. And the treatments, what's interesting is the treatments that are used to try to improve the platelets are ones that affect the immune system, like steroids, or sometimes something called intravenous immunoglobulin or IVIG. And those, since they're affecting the immune system, really would only work if the problem is immune, like ITP. But again, usually you wouldn't even need the treatments unless the numbers are low enough that we think it's ITP. So they usually come hand in hand, meaning if someone has a platelet count of 90,000, we don't feel like they need treatment because they're still in an okay zone.
Yep.
One thing we sometimes consider is if we see a trajectory of them heading downwards, we might say, just so we don't get into that space, maybe we should consider an induction of labor, let's say 39 or 40 weeks, to do it while your platelet count is still normal. Again, that's a conversation. There's upsides, there's downsides, but it's something we might consider either in conjunction with treatment or before instituting any treatment. And one of the interesting things is if we believe it's ITP, that is the one that actually also has a small risk, under 10%, but a risk of the baby being born with low platelets. Meaning if the mother has gestational thrombocytopenia, the baby's platelet count will be fine. If she has ITP, there is a percentage of those babies where the antibodies that are doing it to the mother get to the baby and attack his or her platelets, and they could be born with low platelets. There isn't much we do differently about that, and the baby's platelets are checked routinely after delivery, but it might be a reason why we wouldn't do certain procedures like forceps or whatever if we think that there's a risk of the baby's platelet count being low and not being able to clot their own blood so well. But it does not mean they need a cesarean. It's just something that we make note of and obviously let the pediatricians know as well. So what do you do practically? Let's say you have a situation where you're checking someone's blood count routinely. They're around 28 weeks and the platelet count comes back at, let's say, 110,000.
I would tell them that it's a number.
Mm-hmm.
It's a number that's under 150.
Uh-huh.
But it's over 100, and I'd probably want to recheck it. There's not much to do right now other than watch and wait and repeat and see if that level is going to stay stable or if it's going to start going down.
Yeah, and I think the majority of the time that plan's in place, the number does stay above whatever number we deem is necessary.
Right.
And it just means a couple of extra blood draws, and then they go have a delivery without an epidural, everything's fine. The time when it starts dropping to the point either at or below a number that we're concerned about for an epidural, that's when we consider treatment, with steroids, sometimes seeing a hematologist, maybe meeting with the OB anesthesiologist to find out what their threshold is, potentially inducing labor and whatnot. And if it really drops, below 50 or something, then we're talking about treatment and potentially giving platelets to someone when they're delivering, which is, again, very unusual under these circumstances. And I think that the takeaway message is this comes up a lot in pregnancy. We think about it a lot, but most of the time it's completely benign, nothing to worry about. Everything's going to be fine. And periodically treatment needs to be there or some intervention, but very rarely does it ultimately end up that someone can't get an epidural or needs platelets or will be put to sleep for a cesarean or they'll bleed too much or something like that. That's very, very unusual, particularly if you're on top of it. If we're on top of it as doctors.
Yeah. I mean, the majority of the time, it ends up being a non-issue.
Sarp, thanks for coming on to talk about the platelets.
I love it. Love platelets.
The thrombocytes, as we like to say. Wonderful. All right. We'll see you all. Have a great day. Thanks, Sarp.
Take care.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.